This week we're going to talk about conceptual distinctions and the definitions of the words that we're going to be using in this course. It's important to be clear so that we're all talking the same language and we don't confuse ourselves and talk past each other using different words. So we're going to focus on conceptual distinctions. Remember last week we talked about dialysis and how dialysis was discovered in the 1940s in the Netherlands, but it could only be done acutely for a short period of time because we used up veins and arteries too rapidly. There was a very vigorous research effort to try to discover ways of creating a shunt that allowed dialysis to be done chronically over a long period of time. And then in the early 1960s, the development of the AV shunt, the arteriovenous shunt in Seattle that allowed chronic dialysis to happen. That was a major breakthrough, but it also created a major dilemma. There were a limited number of dialysis machines, and the question then became, who got on the dialysis machines for 3 days a week? Who was selected for those machines? Who would live on dialysis and who would not get dialysis and die? That was a major issue. It raises questions about how do we describe that event. So what we're talking about is the ethics of who gets what and how they're selected. A variety of different terms have been used. Priority setting, resource allocation, and rationing. What are the differences between these terms? How are they the same? Well, let's go first to priority setting. The OED, or the Oxford English Dictionary, has the following two definitions. To give priority to designate something as worthy of special attention. To arrange items to be dealt with in order of importance, from the most important to the least important. Therefore, to establish priorities for a set of tasks. We're familiar with priority setting in the airport setting, where individuals get sorted into two groups. The priority boarding, those people who get onto the airplane first, and then the rest of us who board in general boarding. Typically, priority setting can be a good thing. You are first in line. It can improve efficiency because you know what to deal with first, that's most important, and then secondarily, the lesser important items. It doesn't necessarily presume any scarcity. After all, in the airplane boarding situation, everyone has a ticket, everyone will get a seat. It's just who goes on first and who goes on second. And it often requires criteria. Those people who are in first class or fly a lot get priority boarding. Resource allocation. The Oxford English Dictionary defines resource allocation as a portion of revenue or other item assigned to a distinct purpose constituting a fixed charge upon it. A portion of revenue settled on a particular person, some kind of allowance, or the allotment of available materials, provisions by the government or some other authority into different buckets. As you can see, resource allocation has a more neutral connotation compared to priority setting, and it frequently is done administratively, not by any big authority. It doesn't necessarily presume a situation of scarcity. It presumes a situation where you have to allocate or decide who gets what provisions. It may require criteria, or it can be often done randomly. Rationing is the most controversial of the three terms, and it often has a negative connotation. The Oxford English Dictionary defines it as to supply persons with rations, to provision, to put on a fixed allowance, to divide food into rations, to serve out in a fixed quantity. The third definition is an allowance, a share, a portion of provisions or other supplies, especially an officially limited amount for civilians during times of war and shortage. We're most familiar with rationing during wartime and war shortages, but they can occur in other situations, like the rationing of gasoline during a shortage of oil, not necessarily linked to war. Now, rationing presumes a scarcity of some commodity, whether it's oil or food. It can be a bad thing, denial of services to some groups and giving it and focusing it on others. There's always a worry that you're taking something valuable or important for life away. It often requires criteria. When we deal with rationing, we're dealing with scarcity of resources, some limited amount of a good. Again, whether it's food or oil, It's not just scarcity of money going into various provisions, and this is an important distinction. What is rationing in healthcare? A number of people have tried to define the term. One group defines it as the societal toleration of inequitable access to necessary healthcare services. Is that really what rationing means? Another group says any set of activities that determines who gets needed medical care when resources are insufficient to provide to all. A third definition that has been used in the literature is the deliberate and systematic denial of certain types of services, even when they are known to be beneficial because they are deemed to be too expensive. A fourth definition is any explicit or implicit measures that allow people to go without beneficial health care services. Notice in the middle two definitions, the second definition, any set of activities that determines who gets needed medical care when resources are insufficient to provide for all, focuses on the limited resources. Whereas the third definition focuses on money. It says the deliberate and systematic denial of certain types of services, even when they are known to be beneficial, because they are deemed too expensive. That's an important distinction between these two definitions. Some people have tried to put this into a graphic form. This is Peter Ubel and Susan Gould, and they have this multidimensional graph. At the top, on the y-axis, is absolute scarce resources, so limited number of resources, and the bottom is not absolutely scarce resources, but limited costs. And then there's implicit and explicit criteria, and finally they draw this circle that shows necessary services. Importantly, you can see that the area above the line, 1 and 3, are necessary services using explicit or implicit criteria in a situation of absolute scarcity. That would qualify with the second definition of rationing. On the other hand, 7 and 5, where you have necessary services but they're short because of money, is more likely related to resource allocation. So rationing deals with absolutely scarce resources, where you don't have enough of an item, not enough dialysis machines. And resource allocation we define as where there's not an absolute limit in the actual resources, so like dialysis machines, but a decision not to spend the money. It's more money related. We can distinguish between resource allocation and rationing in the following way. The problem, as we've emphasized in rationing, is that there's an absolutely scarcity. There is a limit on the number of goods you have, the number of dialysis machines, respirators, organs, medications. Resource allocation, it's relative scarcity. That means that there's been a decision not to spend money, but there's no underlying shortage of the good. What are the key ethical questions? Well, when you come to rationing, it's which individuals get the limited number of goods, whether it's medication or dialysis machines you have. Therefore, some people are going to get it and others aren't. Resource allocation is which groups of people will share in the resources. It's not about picking individuals, it's about picking groups where you could, if you had more money, supply them. Are there win-win possibilities? Well, in rationing, there are no win-win possibilities because you're limited by the number of goods you have. Whereas resource allocation, you can create a situation where everyone is benefited. Who decides? Well, typically in the rationing situation, you can have physicians or you can have guidelines. In the resource allocation decision, this is typically done by policymakers or insurers. They formulate laws, regulations, and whatever the policies are to allocate the resources to individuals. So let's be quite clear. Rationing, in our definition, as we'll use it in this class, is to regulate access to beneficial health care under conditions of absolute scarcity. There is a limit, a finite amount of goods. Resource allocation, on the other hand, is to regulate access to beneficial health care under conditions of relative scarcity, where relative scarcity means that there's been a decision about how to use the money, but there's no underlying limit of the good, whether it's the medicine or the machines. Let us apply these conceptual distinctions we've raised to the dialysis case when dialysis had first become possible for chronic renal disease by the AV shunt in the early 1960s. So in the early 1960s, there was absolute scarcity. There were a limited number of dialysis machines. Only 1 in 50 people who had kidney failure could get on the dialysis machines because people needed to be dialyzed 3 times a week. So the question was, who got time on the machine? On the other hand, when dialysis became paid for by the government and a lot of machines were produced, there was no limit to the number of machines, but there was a relative scarcity. It was now quite expensive to provide dialysis to all the people who needed it. In fact, for a very few number of people, it was 1.2% of all Medicare expenditures, more than $25 billion for the people who are getting dialysis. The key ethical questions, therefore, in the early 1960s, when you had only a handful of machines in Seattle, was who to get on those machines. The God Committee, as we discussed last week, decided that had to be a person who lived in Washington State, had to be someone who deserved it. That is, by their criteria, whether they were employed or they were religious. They also evaluated whether the person, if they died, would leave a burden on society. And they finally looked at whether the person would benefit, mainly go back to full employment. When the government took over paying for dialysis in the 1970s, it was a very different issue. They decided to pay for everyone who needed it. The key ethical questions were less who got the machines then, how much to pay for people. Can prices for the machines be reduced? Could we provide a smaller benefit package so that more people could get on the machines? A very different problem. When you have rationing and a limited number of dialysis machines, there are a limited number of solutions you can do to get out of the problem. Once you have people with kidney failure and you have a limited number of machines, you simply have to decide between them. On the other hand, when you have resource allocation, one of the solutions is to try to reduce waste, to reduce unnecessary care, to really hone in your resources in what's going to make the best items. It's really about how much you're going to spend for people, not who gets it. Is there a win-win possibility? Well, in rationing cases, it's typically a tragic choice. Some people will get, others won't. That's initially. But when the government decided to pay for it, suddenly manufacturers could produce a lot of machines, hospitals could buy them, and it was not a question of who got dialysis. It was a question of, well, if we're spending money on dialysis, what aren't we going to focus on, or what's going to get less money? Finally, question of who decides. Well, in the case of rationing, as you know, they created a committee of civilians in Seattle to decide which among the medically eligible patients would get dialysis. It was called the God Committee. Initially, the physicians determined who was medically appropriate for dialysis, and then the so-called God Committee of civilians had to decide which among those eligible people got to receive dialysis. On the other hand, in resource allocation, it's typically a decision made by policymakers, by a formula or by a law. Here's what we're going to cover on dialysis. Here's all the added medical services that will be paid for. It's really a decision of how much money to spend, not which people. And it's not typically made by doctors, but made more by policymakers, insurers, lawmakers. Rationing and resource allocation can occur at different levels. Typically, the rationing decision is at the physician-patient level, the micro level. There's also a macro level where the government sets guidelines. For example, the government setting guidelines if we had too few vaccines in a situation as to who would get the vaccines first. Often these decisions, especially resource allocation decisions, can be made at a meso level, healthcare organizations, insurers, or hospitals under certain circumstances. Rationing decisions can frequently be made there as well, or at least guidelines for rationing decisions. For example, when there's a shortage of chemotherapeutic drugs for cancer patients, frequently hospitals will decide which among their patients will receive priority in getting those limited drugs? Will it be patients whose cancers can be cured, patients who are on research trials, or other types of criteria, younger patients versus older patients? So let's summarize. Remember, rationing is to regulate access to beneficial health care under conditions of absolute scarcity. That means that the medical service itself, the medical resource, whether it's organs or drugs or dialysis machines or respirators or hospital rooms, they are in short supply, and you simply cannot solve the problem at this moment. You must choose which patients get it. Resource allocation, on the other hand, is to regulate access to beneficial health care under conditions of relative scarcity. It's not a limited good. It's about how you're going to spend the money that's available, which of the various services gets the money that's needed. So that is what we're going to be doing. If there's a resolution to the debate about, if there is to be a resolution to the debate about compromise in clinical care, it must come from discussion of what actually happens, rather than just a debate about the language, whether this is rationing or resource allocation. So once we're clear on the language, we'll be able to focus in on the ethical issues underlying the problem. Thank you.